first panel, of course, reflected the enthusiasm and brilliant ideas of the private sector. And of course, this is a panel that's going to say, well, we don't know about that for the government. And there's some truth in it. Rishika, actually, I thought made a few great comments that fit right in with this panel, such as, well, all you have to do is get Medicare and Medicaid to change the entire operation, and it should be easy to transform the health system. Yeah, that wouldn't be bad to do. Or the way he put it, he referred to the pietà, just get rid of what you don't want. Well, yeah, except that as we all know, those of us who have stuck it out this far, everything is an entitlement in the health sector. It's not just the entitlement to patients or beneficiaries of the Medicare and Medicaid programs. It's an entitlement to the providers. It's an entitlement to the insurers. It's an entitlement, by the way, to everybody because, of course, everybody, one way or the other, is getting a subsidy, either through the tax system or directly. And, of course, the only lesson you need to know about Washington is you can't ever take anything away from anybody. Or at least you can't do it directly. So I think all of our experiences has been that Medicare has been successful at doing two things at once. The most important thing, telling beneficiaries, no, we're not affecting your benefits or anything else about your health care. And on the other hand, periodically reducing payment updates, which is just an indirect way, if it actually sticks, it's an indirect way of affecting how healthcare is delivered. Similarly, in the Medicare program, we have all these innovative ideas, ACOs, for example. But ACOs, of course, were not invented out there in the real world. They were invented largely in Washington. And that's, I think, been one of the issues with those kinds of innovations. I would also point to the bundling projects as well. Why have they worked out or not worked out very well, as has been the case? Well, I think it's partly that the Medicare program in particular has been structured in a way for a very, very long time that makes it difficult to move. And when you make changes, you are not only potentially changing the way healthcare is delivered, but more importantly, you're redistributing money. You may be taking some away, probably not, but you're redistributing it. So there are winners and losers. And the winners are grateful and are quiet, and the losers complain. So this poses all kinds of challenges and problems. That isn't to say that private sector proposals can't work. It's to say that it's very, very difficult in an entirely different situation when trying to change government policy. One other observation, from the first panel that I wanted to emphasize, and one of the early speakers made the observation that his company's innovation was going to work for essentially a large, fairly permanent workforce. Now, you might say that the Medicare program, we're not exactly, those who are in the Medicare program aren't workers, but they're permanent. So you would think that the Medicare program could actually take advantage of these kinds of innovations that have a long-term payout. And yet the Medicare program is locked into the same exact structure that the rest of the health financing system is locked into, which is it's a short-term perspective. It's a one-year perspective. Maybe it's a two-year perspective, but it's not the long-term. Medicare shouldn't have that excuse, but I believe that's where we are. Anyway, with those words of encouragement, let me turn to Gail Wilensky. Gail is, actually, let me introduce everybody so I don't fail to do that. Gail is a senior fellow at Project Hope and was administrator of what is now known as CMS, used to be called HCFA. Then the next speaker will be Mark Miller. Mark Miller was the longest serving executive director of the Medicare Payment Advisory Commission, which is, for those of you who may not know everything about it, is an unusual group of people or organization because they're advisory, but their advice actually has weight, and it is based on detailed understanding of the complexities of the Medicare program. And Mark is very much responsible for that. He has moved on to, let's see, what is your title, Mark? You are Vice President of Healthcare at the Arnold Foundation. Then next we have Chris Jennings. Chris, as I think many of you know, has been deeply involved with health reform, at least starting with the Clinton health reform in the 90s, but continuing on for many, many years, has held positions in the Congress and White House and other places. He is now the head of his own consulting firm, the Jennings Policy Strategies Company. And then finally, we have Lanhee Chen. Excuse me. And Lanhee is the David and Diane Steffi Research Fellow at the Hoover Institution, and is a frequent interviewee on numerous television programs, news programs, and is on numerous panels. And he lives in California, so we're lucky that he was willing to come this far. So with that, Gail, please take it away.
The general topic we were asked to speak about are ways to translate from the private sector into the public sector, and the kinds of barriers that we see in the way. I think that was ultimately what Joe wanted us to focus on. Listening to what was said, augmenting the work I'm already aware of through the Peterson Center and others about what is going on in the private sector, and thinking about what they've said, has helped me to focus on a couple of areas where I believe we need to get agreement first. And it's an area where government may be able to lead, although ultimately who is regarded as the convener may become important because of update impediments that get involved. And what I'm thinking about here is the repeated indication in different ways about the importance of measuring what matters to patients. And that I have been overwhelmed recently by the proliferation of metrics that are now in use when you consider all of the demands and requirements that come out of CMS and the government with regard to measures they want, and frequently the different measures that the major private payers, the Anthems, Uniteds, the Aetnas, the Blues plans, may also put on. I think it is time now for some government leadership to try to convene to get what would generally become a more unified set of measures. I've been very uneasy about doing that up until now because I think the science of the metric measurement was too early, and I think it is obviously still evolving. But I think it is time to try to do that in a more coordinated way. Putting a lot of emphasis on something we heard this morning, which is obvious but gets lost in the shuffle, which is remembering that first and foremost it has to be what's important to the patients. It doesn't have to be and shouldn't be only what's important to the patient, but that has to be a key component. Not just because that ought to be driving how care is provided, especially for us market-based economist types. The patient can define better what's important to the patient, what matters, than any other individuals, even if objectively they may be regarded as knowing more about the particular area. That doesn't mean it's what the patient values, even with a reasonable amount of information. It does indicate that it requires a willingness for public and private sectors to work together in a way that has not happened very often. And to the extent it's possible, I know that there have been some efforts going on in the last year that involve AHIP and CMS and many other private groups to use administrative data. It would certainly make life much better to have that be a key but not exclusive focus on how you collect data, so that you can try to minimize the burdens that we are placing on institutions and clinicians in getting this data. It must be overwhelming to both the institutions and the clinicians because of all the different demands that various payers or other standards or boards put in terms of what they have to provide. And again, really focus on the fact that it's not the right treatment if it doesn't get at what matters to the patient. And even if it is technically correct and efficiently provided, if there's an error in the diagnosis or an error in the treatment chosen given the diagnosis, everything else kind of falls apart. And many of our current measurement systems open themselves up to that kind of a problem. The second thing is going to be it's time for the public sector and Medicare to make some decisions about how to move forward on trying to look at value-based care, again, defining, making sure that the key to that is what matters to patients in terms of how you define that quality. I think we are ready to take our best shot now at what the next venture of payment systems in Medicare ought to look like. What has gone on with CMMI in the past 5 or 6 years, I think, has helped frequently by telling us what doesn't work. But that's not a trivial issue either. It won't be the last change that gets made in Medicare. Congress meets all the time. They have Medicare bills most years, or used to have some kind of Medicare provisions most years. When they need to change it, they can change it. But I think it is time, gather, get some agreement, move forward. The challenge that we can see is when you end up having to rely on the political process, you really are likely to get a camel at the result, hardly a pieta. And we are seeing now the struggle clearly identified by MedPAC with implementing the macro legislation, which was very important, moving away from the micro unit fee-for-service system that was the relative value scale. That was the most dysfunctional way we could pay for physician services. But I think MedPAC has been very clear in its recommendation now that we're not really ready for the fee-for-service part, that the merit incentive payment system, the MIPS, to put that into action in January, and we need a quick huddling to figure out what to do in its place. So it is, I mean, the barriers are challenging, but I think it's a place where leadership in trying to really keep your focus on what it is you want to do and minimize the burden is something that Medicare needs to do pronto.
Thanks, Gail. This question about what CMS can do, given that MIPS probably isn't going to arrive on time, is a really good question. I know Mark, in his role with MedPAC, has some thoughts on that. I mean, one of my questions, this is really more a question for Mark that you might address, or you probably will address in your comments. But what do you do in January?
I don't have that addressed in my comments.
Good. That's a good answer.
Ask for a pause.
Do you want me to go on, or do you
no,
want
well,
to discuss MIPS? Because I could do the whole 10 minutes on that if you'd like. But if you want to come back to it on questions, I think it is something. You want to read mine? That's it. Okay, so we were asked to talk for 10 minutes to try and talk about this translation function between the commercial and Medicare. And so I would like to thank all the sponsors for asking me here today. I appreciate that. It's always an act of courage to put me in front of a microphone, and I appreciate you taking the chance. I'm as nervous as you are. There's a couple of things that I would say in thinking about that translation, and I am going to say some things that I think overlap clearly on the themes that were made by the other panel and by the speaker, by the secretary this morning, but just a couple of things to kind of set the stage. You know, I think of things in this talk from a cost containment perspective, and in the private and Medicare, commercial and Medicare sections, there are different drivers of the problem. In the commercial sector, the biggest problem as far as I'm concerned is provider consolidation and prices. On the Medicare side, it's an influx of the baby boom. You have some utilization issues, but you have mostly control of the prices, with a huge exception being drug prices. And one thought there is to keep in mind is as you import ideas from the commercial from the commercial sector, don't import the prices that they're paying from a dysfunctional market as you think about policy there. The second thing that I've run into repeatedly throughout my career is people who come from the private sector, well-meaning, thoughtful, all the rest of it, and say, you know, you should take this idea and you should implement it in Medicare. And I would say, you know, think about that comment just a little bit more carefully. These ideas are often incubated in environments where you have a network of providers, a linkage between a patient and a primary care, you have utilization controls, you have financial incentives for the beneficiary. That idea may be very relevant to the managed care sector, may be very relevant to the ACO sector. It could hit Wild West fee-for-service and not only not work, could actually become a point of abuse for the program. Yeah. And so as you carry an idea from the commercial sector to the Wild West fee-for-service, think about how you make sure that that idea works in an environment where some of the tools that you built it on don't actually exist, or carry the idea elsewhere into Medicare. Of course, that raises issues about changes that should be made in Medicare, and hopefully I'll say a few things about that as we go. The other thing I want to say, and you know, the commercial sector has much greater ability to have financial incentives for the patient or the beneficiary, however you think about it. Financial rewards to choose low-price providers, value-based insurance design, employee incentive programs, that type of thing. Those types of things in Medicare are much more difficult. They require changes in law. Even in the demonstration space, the flexibility to adjust the patient liability is much more limited. And then you have this behemoth first dollar coverage wraparound from Medigap and ESI coverage, where if you put those incentives in place, they can be completely blanked out because the patient can insure themselves against it. And that's something that needs to be addressed in Medicare. Just a couple of other, these are free of charge based on things that people, all that other stuff you're being billed for. So, you know, there were comments made on the second or the first panel that said, you know, money drives delivery reform. Money matters, and I believe that very strongly, and payment mechanisms matter. And I also think this, that when providers or you know, commercial sector actors come to Medicare and say, I have an idea, and that idea I think should involve accepting risk. The trade-off for that is that the Medicare program should remove regulation in exchange for that. You take risk, you take then Medicare walks away from the regulatory requirements, because the regulatory requirements are often in place in Wild West fee-for-service for that percentage of providers who will abuse the system. And as long as you're assuming that risk, then Medicare should say, fine, these rules no longer apply, just as a matter of principle. Okay, in case you're wondering what's going on, I am decidedly wondering what's going on, because once I start talking, I generally black out. Now what I'm going to do is try and relate much more directly to the first panel, some things that they said and how they relate to Medicare. So here we go. First of all, I think it's on primary care, a lot of discussion about primary care. I think it is important that there is a direct linkage between a patient and a primary care provider. I think that's something that, in ACOs, there should be a harder linkage, and maybe even in fee-for-service generally, and ideas like soft lock-ins for beneficiaries. With respect to paying the primary care physicians, we are paying too little, and we should rebalance the fee schedule. And I don't want the orthopedic surgeon to freak out, but pay less there and move money over to the primary care. He's a big guy, could get right over the table really quickly, but that's sort of my position there. And we should pay the primary care physician on a block basis, and I think that allows the primary care physician to spend time doing non-face-to-face type of work, and also engage in coordination with specialists and social services and that type of thing. I do think it makes sense to pay a lot of health care on a procedure-by-procedure basis, but not primary care. Okay, benefit design. I think that the fee-for-service benefit nobody really talked about this. So I'll tell you what, I'm going to go to payment reform. I'll come back to that if there's time. On payment reform, I think that the Medicare program should stay focused on ACOs. I think the evidence has been small, but it is relatively significant, and I think there should be changes there, which I'll say in just a second. I think those kinds of mechanisms should be in place because utilization slowed down in Medicare a lot, also in the commercial sector, but I don't think anybody really understands why, and if it were to accelerate again, you would want mechanisms like ACOs around. I think Medicare should move aggressively towards two-sided risk, and I think to make it more attractive, you have an asymmetric risk corridor, more upside than downside. I believe you can do that in a budget-neutral way. All of these ideas, I believe, can be done in a budget-neutral way. And I think, as I said, if you embrace two-sided risk, there should be a lot less regulatory requirement when the ACO does that. I think there should be some support for small ACOs by scaling the risk to the volume of their business. I think we should be promoting all-payer ACO collaboratives like the Vermont initiatives, which brings together the commercial, Medicare, and Medicaid, and has all of the hopefully we'll get all of the signals aligned. And I think drugs should be added to the ACO targets. It's a huge technical problem, but I think it is something that actually should be pursued and could be, you could get there. On bundling, and I thought I was going to sort of explain some of the problems with bundling. I think you got an incredible lesson in the bundling problems from Kevin on his experiences and the directions he was going. The notion that it can result in more episodes, it doesn't stop episodes that shouldn't happen, and I worry it undermines population-based models and sort of has the savings come out below the population level, where the population level would have an incentive to avoid a surgery that was completely unnecessary. I worry that you can refragment the system and still be generating volume. The other thing is, I think that there are a lot of bundling problems that are models that are being put forward that I see as sort of more motivated about protecting specialist revenue really than about reorganizing care. Now that said, I wouldn't say no bundles, zero, all the rest of it. I think there are, and I think surgery surgery and post-acute care related to surgery makes a lot of sense, and so I wouldn't say hell no, but I say it should be targeted and somewhat limited. I'm going to finish up with quality. I didn't think I was going to talk about quality, but everybody else did, and this is a panel where you're supposed to free-form things, which is also why I'm really nervous. So the last thing I'll say about quality is you heard this, relatively consistent comments of like, we're measuring too much and we're measuring the wrong stuff. Anybody who has followed the MedPAC folks, MedPAC has been on a pretty full-tilt rant on this point or a considered conversation on this point for many years. I think this is a place where Medicare could lead. I think if Medicare said there is a small number of outcomes-based measures, and that would allow Medicaid and the commercial sector to align around those and say, this is what we're going to do for payment purposes, and leave flexibility for providers to measure and systems to measure their quality below that and move performance as they see fit, I think that would help remove the burden. And notice that in outcomes-based measures, in many ways, there are certain forms of those you don't even have to bother the provider to get. And so you could reduce burden, reduce the administrative cost, and at least send from a payment perspective a relatively clear signal. I'm at 9 minutes and 54 seconds. I had 10 minutes, and we're done.
Well, Chris, that sets a mark for you.
Well, let's see. I'm on 1 second. I'd say that I would say that Mark just gave you one of the most amazing presentations you'll ever hear. He gave you, if you can keep up with it, that's the issue. I hope someone has recorded it, because there are a lot of extraordinarily important ideas that he just conveyed. I think what I'm going to talk a little bit about is just a little bit of observation, Joe, about what happened this morning and their application. I think we heard something that's really important, which is this whole focus on really a greater, and we just heard from Mark, a lot greater emphasis on primary care and giving them more both resources and flexibility to administer and manage populations from the beginning and down the stream, all the way to, and in particular, the two areas that when I talk to plans in the private sector, they'll talk about two issues in particular, and that's their ability to do referrals better and get information for referrals who do a better job, and also to manage drug costs downstream. And they're a much better population to rely on in that regard, and I think we have not maximize the potential there, and I think that I've seen that plans are moving in that area, and I think that that's encouraging. And the private sector, I think, is ahead of Medicare in doing some of those things, and I hope we can transplant that a little bit quicker. The other issue that I was really frustrated to hear about was this whole conversation about quality and quality metrics, and I'm frustrated because this is not new. We have been talking about outcomes-based research and consolidating measures for 15 years. I mean, literally for 15 years. And so when this is a novel conclusion, you kind of have to come to you have to stop for a moment and say, okay, why is that the case? And there are two reasons why it's the case, and they tend to be stakeholder related. One are the plans and Medicare all have a whole different array of measures that they want to be applied. And they all become, after years and years of developing them, have become extraordinarily invested in maintaining them. And so when we can have a panel like this today, where we had the plan saying, oh, I'm all for it, they're all for it as long as it's their measures, and there's 4 other plans that physician is trying to deal with. So, I mean, you got to be a little bit sympathetic to the physician community who's like just going crazy. But on the other hand, I have been in room after room after room with the physicians communities, and they'll say, anything but outcomes-based research. I have a measure that it would be much better, and you just don't understand it, and it will require too much upon me to do it. And so, let's look in the mirror and say the problem is the very stakeholders who have been embedded in this discourse forever and ever, and we use them, we say, okay, let's get around the table and we agree to let's keep our measures. And someone's going to have to say it. Maybe it's the federal government. I don't care who it is. But this is what we're going to do. And by the way, it will not be perfect. It will not be perfect. There will be a 1.0 and a 2.0 and a 3.0, but we're going to start, okay? And so when I heard Secretary Azar this morning say, we're going to start on drugs and we're going to make mistakes along the way, good. Welcome to the debate. I'm so happy someone is doing it. And when they propose an RFI that provides more flexibility to do some of these innovative things at the primary care level, huge. Let's go for it. Let's maximize the potential. Let's praise them. I'm a Democrat. I praise you, Secretary Azar, for moving that direction if we can do that. And I praise him for doing that on prescription drugs if he can find different ways to do it. I suspect he will find that he's going to fall short on the pricing objective that he wanted on drug prices, but, and that competition only goes so far when you only have a single source drug, and the single source drug can charge whatever they want, and I don't care who you are as a purchaser, you can't do anything about it. So, good luck, but welcome, and there's some important contributions that he laid out this morning that I think are encouraging. So Joe, don't be so discouraging. There's there's positive. On the private sector and on bundling, I heard the doctor talk about, I think, bundling, which I thought was interesting. Bundling not by procedure, but by condition. That seems interesting to me. The only thing that I wonder about is every time, the only thing that Mark has told me, and Gail as well, is that translating some of these concepts in the Medicare program is very, very difficult to do because you have to first, and this is another subject that I want to talk about, which is this issue of how do you set the bundle in the first place? How do you set what the amount of money should be, and what is the baseline going forward, and how do you update it over time? Because there's a question about whether you can keep people in the game over a period of time once you have done that. And someone has yet to explain to me how that is a sustainable model over a period of time, and Lanhee, you'll explain that to us later, because I'm sure my time is coming, and I can't even figure it out. Face doesn't work, so.
There will be.
I have plenty of time. I do want to say that to the employer community, and that I love the employer community, but Boeing is an outlier. I mean, we have not seen the engagement of the employer community to the extent that we need to see the engagement of the employer community in the cost debate. And and there's reasons for that, and I'll explain it. It's their third or fourth or fifth priority. That's where they are, and so they'll complain about it, but they'll complain about it not as much as you would hope, because I'm telling you, we need the political cover of the employer community to get the policymakers in Washington to do the type of things the employer community wants Washington to do. Okay? I mean, I'm telling you, Republicans and Democrats, all of them up there will say, if you want me to take on the stakeholder community, the consumers are not going to be enough to do that. I need to have the employer CEO community at the CEO level engaged and promoting policies that they want to see get fixed. Otherwise, don't complain so much, because then we're going to just go along our merry old way and do what CMS always does. They'll do what they can with a Medicare program. But to that end, look at the employer community's recommendations in the general level, with stuff that Eric has done. There's some really important things, which include a lot of the data information that needs to be out on the table, the transparency information, the outcomes measures that they explicitly are advocating very publicly, the financial incentives for both providers and for patients. There's some very good ideas there. But in order to get those seriously taken and to take on the provider community and the stakeholder community writ large, they need to step up. I'm sorry. And, I hear you talking about prescription drug costs, but, let's step up. And what else do I have? I'm almost done, I promise, Joe. A couple other things. Attribution, risk adjustment over a period of time, very, very difficult to do within the Medicare program. You're going to say to the provider community, do this. Well, they don't even know who's in the program on attribution. We've got to figure out ways to do that. And if we're going to be looking at populations and we're going to ask them to seek bundle payment rates, of course, the first thing they're going to say is, well, my patient is sicker than the other patients that are in this bundle. It's not fair. Fix it, Mark. So if you could fix that at some point going forward, I would be very happy to advocate for that. And lastly, I don't have any time left, but MACRA is frustrating, Joe, yes. There's lots of problems with it. I looked at, even MedPAC said maybe we should start all over again, I think. Maybe we should. But I will also say one thing about it, which is you have to understand what happened with MACRA. MACRA happened because the physicians were tired of the annual debate around SGR. Okay, it really wasn't a discourse about how we're going to change the delivery system healthcare. That was cover to do that, okay? And then everyone said, oh, we've done it, and we're going to have something that isn't ACOs. We'll call it APMs, and it will be something creative because it's not the Affordable Care Act, and it will be good, and we'll go ahead and implement it. But then we say, but we should exempt like hundreds of thousands of people from its rules, and therefore, guess what? It's not going to happen. I would suspect it was done in an unrealistic way. I think the incentives are all wrong. I would follow some of Mark's prescriptions in that regard, and I think in the Q&A you should ask him some questions about MACRA, about what we should do next. So with that, I'll conclude. Thank you very much.
Thanks, Chris. Lanhee.
So I guess I'm here to channel Joe and dash all your hopes and dreams about what's next. So let me just say I think there's a couple of different themes that are important to think about as we have this discussion. First is, what is the proper locus of a lot of this activity? Is it the federal government? Is it state governments? And then within the federal government, how much of this can be accomplished via administrative action directly by the agency or its component parts versus the need for an act of Congress? That's one issue that the Secretary didn't get into as much this morning, but I think it's an open question how much the administration is going to be able to do on its own. And I think that relates in part to how aggressively they're willing to use CMMI, which has been an area of skepticism. I've had my own qualms with it, and I think a lot of conservatives have expressed some skepticism about CMMI. But ultimately, it falls to this question of how much authority the administration is actually going to be able to exercise on its own. Now, I think the states should not be ignored, because one of the issues that came up earlier was scope of practice laws. Well, that's something that states could very easily decide they wanted to address in the absence of federal action. So I think even if we are gridlocked at the federal level, and even if there is an issue with how much authority this administration, or any administration for that matter, actually has to move the needle, the broader question then is, okay, what might governors and what might states do, and how can they leverage their Medicaid programs, for example, to begin to move in the direction that we want to see as we make this transition? So that's sort of the first set of questions, is around where people think this activity should take place, and where there might be some promise to move the ball forward. The second issue is the politics. I know no one likes to talk about politics in this town, I get it, but the politics actually are very important here, because just as with the North Koreans, the era of strategic patience may be over when it comes to the migration toward value. And what I mean by that is this. I think, Chris, you made a very good point, which is that employers have the opportunity to jumpstart this discussion. And this is not going to be something that's going to happen above the radar. And precisely for that reason, this may be something that actually happens. Because so long as you don't need to be dealing with the ACA wars, which will continue, no doubt, I think you can actually make some progress here. And I think that there is a shift at the agency. Alex Azar is a very different kind of secretary from what Tom Price was, in a lot of ways. Alex, the secretary, I think, represents a a much more traditional view of the need for the agency to take an aggressive role in facilitating this migration to value. And I think that change is actually very meaningful. So the political will, I think, is there in this administration. That's the sense I get, at least. And in that sense, it matches up with kind of what I think this town is able to handle right now, which is not a lot, frankly. I don't think we can expect, for example, the Congress to come in and be super active on any of these issues. Yes, a lot of bills come up on Medicare and Medicaid. How many of them actually get acted on? Precious few. And so I think that the need for administrative action, the need for there to be some kind of motivation, again, I think employers can provide that, I think will be a very, very helpful set of motivating factors as we move into 2019. And I would suggest that a lot of this is 2019 activity because we're all about to shut things down for the election in a few weeks. So, there is the potential for, I think, the political supply to match the political demand when it comes to under the radar type activity, which is largely, I think, what we are all in the vein of talking about. So, with that, I will end early, and we can have a discussion.
That's great. Yeah.